Very good evening and welcome to one and all. I am Momita from Clarinet, the designated session assistant for a seamless experience. And Clarinet is India's most trusted and widely used digital platform with multiple enriching services exclusively for doctors. Clarinet is very proud to be a digital partner for this event organized by Oncology Integrated Society. And the topic of today's session is the recent scenario on the management of cervix stage wise.
Cancer cervix.
Cancer cervix stage wise. So let's begin today's session, for which I would like to invite Dr. Dipti Chaturvedi ma'am to take over. And
Okay, thank you, Momita.
thank you, ma'am.
Just put the
Over to
slide
you, ma'am.
of Deep Prajwalan.
Yes, ma'am. Is my screen visible, ma'am?
Yes.
Yes.
Thank you.
Now I will request Dr. A.K. Chaturvedi. Are you there?
Yeah.
Dr. A.K. Chaturvedi?
Yeah,
please recite the IMA prayer. IMA prayer.
We'll begin with our IMA prayer. Sarve bhavantu sukhina, sarve santu niramaya, sarve bhadrani pashyantu, ma kaschit dukh bhag bhavet. Na tvaham kame rajyam, na swargam, na punarbhavam. Kame dukh taptanam, praninam atmanasnam.
A little bit of the meaning.
इसका मतलब है कि हम सभी प्राणी मात्र जो संसार में रह रहे हैं उनके सुख की और उनके अच्छी भविष्य की कामना कर रहे हैं और
वे निरोगी रहे।
हाँ, वो निरोगी रहे। ना हमें राज्य की कामना है, ना स्वर्ग की, ना पुनर्भव की। हम सिर्फ मरीजों के दुख को हरने का भगवान से प्रार्थना करते हैं।
So now with this we will start. We are having a very brilliant topic and brilliant speakers and chairpersons. Topic is the current scenario in the management of cancer cervix stage-wise. We know that cervical cancer is a disease of the reproductive age, mostly around 50s, and there are only 20% of the cases which are about 65. So cancer cervix is the third most common cancer of the women. Head and neck cancer and breast being the first and second respectively. As per medical journal Lancet, 40% of the deaths that occurred worldwide due to cancer cervix, 23% were from India and only 17% from China. So India ranks nearly second or third. Incidence of cancer cervix is 6 to 29% of all the cancers in females, highest being in Mizoram and lowest being in the Dibrugarh. So where there is education, where there is screening, vaccination, due to prevention, the incidence is less. Now about the survival, when it is detected in early stages, survival is very good, 92%. And before that, 100%, because it takes 10 years for it to develop from dysplasia to 0 stage, then to SIN 1, 2, 3. And when it has spread distantly, the 5-year survival rate drops down to hardly 7% in best of hands. So for this, today we have a very good, my mentor and the president of Gorakhpur Obs Gynae Society, a very beautiful, ageless, and a woman with a tender heart, and expert by her profession, Professor Reena Srivastava. She is ex-HOD, VR, Medical College, Gorakhpur, President UP Chapter, OBGY, President Gorakhpur Menopause Society, and she established the Menopause Society in November 2016. And she has had many other posts other than being HOD, Treasurer, Secretary, and President of Gorakhpur OBGY Society, Chairperson of the College Research Council, Proctorial Board, and AIDS Committee. She has organized UPCOG in 2003 and 2016 at Gorakhpur, CEFOG, and North Zone Foxy at Gorakhpur. She has organized numerous CMEs and workshops at BRD and has many publications of national and international fame, authored many books, authored chapters on fluid and electrolyte balance, and she has been facilitated for her outstanding work of humanity by both Dainik Jagran and Amar Ujala. And here she is, the brilliant and the women of substance, Professor Reena Srivastava. Please take the chair.
Thank you,
Chair
Deepti, for so nice words. You feel like that? It's nice of you.
Honor to be with you.
Thank you so much. And thank you for inviting me for such a brilliant session. I would like to introduce Dr. Swati, although on this platform, I think I have introduced her in the past also, but she needs, because she's having a brilliant career. Dr. Swati, she is a robotic uro and gynae oncosurgeon at Apollo CBCC Cancer Care, Ahmedabad. She's a leading cancer surgeon with an experience of over 15 years in the treatment of uro and gynae cancers. She has successfully treated hundreds of such patients with robotic, laparoscopy, open surgery, wherever, whatever need be there for these cancers. And she's one of the few doctors to have experience of at least 10 years in robotic cancer surgeries. She's specialized in organ and function preserving cancer surgeries like Neobladder and all, as well as extension, IBC and all. Areas of expertise, urocancers, gynae cancers, and other pelvic cancers. And she has been trained at MAMC, New Delhi, DNB Surgical Oncology, Rajiv Gandhi Cancer Institute, New Delhi, and training in robotic uro and gynae cancer surgeries from the Pioneer Institute, New Delhi. Professionally, previously she worked as SR and consultant robotic uro and gynae cancer surgeon of RGCIRC, New Delhi. She is one of the, I've already told you, then received award for best video presentation on robotic RPLND in NatCon and for paper presentations in CELSICon, IMSCon, RGCon, ISGCon, invited for master video sessions on CRS, HIPEC, and robotic surgery in multiple national and international conferences. And she has got multiple publications in indexed journal. Such a brilliant CV of Dr. Swati. I request you to please start your deliberation. Dr. Swati, please.
Thanks a lot, ma'am, for the kind introduction. I'll just start with my talk, and it is a pleasure to be here again. So my topic is recent scenarios in the management of cervix cancer stage-wise. And I had already planned that I would speak only on the surgical perspective. So it is good that Dr. Chaturvedi will take the lead to complete it with the radiation therapy part, because most of the time CA cervix is now treated with radiotherapy only. So I'll just focus on the surgical perspective, because that is the only area I would be able to speak on. So coming to the our plan, so I put it under 4 headings. One is cancer prevention. If we are going to fight the cancer, one is the cancer prevention. Second is, now we know lesser is better. Third is play aggressive when required. And fourth will be stay calm and aggressive. So these are the 4 headings in which I will be covering my talk. So first, cancer prevention. We all know it is a preventable cancer, CS cervix. So though it is the most common cancer, most common gynec cancer in Indian females, but if we think all around, if we are vaccinated or our neighbors are vaccinated, but the situation is grim. So it is time that we plan a vaccination drive, and in this vaccination drive, we should be educating, we should spread the awareness about the vaccine that is available, the time that it should be given to the girls, 9 to 15 years, can be given up to 35 years. The major change that happened is even the 1 dose is good enough now, as per the latest update. So it increases the compliance of the girls coming for this vaccine. So it is important for us to start the vaccination drive. If we think that we start with each one, teach one, then we take up the school and college program. If each of us takes up a school or college program to educate the girls and get them vaccinated, we can definitely make our state the cervix cancer free state. Coming to the next thing, that is preventing with colposcopy and treating the precancer stage. So colposcopy is done to identify the precancer stage so that we can identify the dysplasias and prevent cancer by treating them with LEEP and cryosurgery and laser also. So that was about the precancer stage and preventions. Coming to the CS cervix, the latest changes that have happened is in the staging. So initially, for last many years, we have seen that it has been divided into 1B2 and 1B3 as per the stage, as per the size, because the radiotherapy was coming up in greatly. So that is why it has been divided into B2 and B3. 2A is also divided as per the size. And the latest change is that the imaging has been added to show the importance of nodal status in staging. So it is no more a clinical staging. Imaging has to be done to find out the nodal status and stage it. Coming to the lesser the better. So lesser the better means that we are not able to, we no longer believe in 56 meals. वो 56 भोग पे अभी हम believe नहीं करते. We move to the diet plan in which we are taking more of the salads and some things like that. So yes, lesser the better. So in this I will be talking about fertility sparing surgery, the type 1 and type 2 radical hysterectomy concept, that is we do modified radical hysterectomy in certain cases, and yes, minimal invasive surgery for cervix cancer too in some situations. So as per the guidelines, if the patient wants the fertility, we have 2 options, that is conization and the radical trachelectomy. In this, a cone biopsy, the cervix is removed as a cone. As per the guidelines, we can do it only in very early, that is microinvasive cancers. Radical trachelectomy though can be offered up to the 1B1 stage, and a lymph node dissection can be included if the patient wants the fertility to be preserved. Coming to the next 1A2 and 1BB cancer, 1B1 cancers. In this, we can do type 1 or type 2 radical hysterectomy, that is modified radical hysterectomy, in which we do not go lateral to the ureters. So this is the important aspect. We need not do radical hysterectomy, complete type 3 radical hysterectomy. We can do type 1 and type 2, that is depending on how much the vaginal length, uterosacral and parametrium is taken. So that is that can be done, and that can be done with minimal invasive surgery. So important thing is the cancer has to be very early. It should be involving the endocervix less than 2 cm, and if we are offering minimal invasive surgery, there should not be any contamination. Though there is a paper suggesting that minimal invasive surgery would increase the chances of recurrence, but in very early stage, properly selected patients, we can offer minimal invasive surgery in these patients. The rationale behind of going for minimal invasive surgery is it not only reduces the infection, hospital stay and blood transfusion, but also the rate of thromboembolism, which can lead to mortality. So that is the most important cause of using minimal invasive methods in these cases. So this is the case of laparoscopic radical hysterectomy, type 2 radical hysterectomy, in which we first create the pararectal and paravesical spaces, go to the uterine vessels. This is the pararectal space being developed, ureter, internal iliac and uterine artery bounded by. This is the paravesical space being created, and this is the uterine artery. So in the type 2 radical hysterectomy, we will be just clipping and dividing the artery lateral to the ureter. We are not taking it at the origin as we do in the type 3 radical hysterectomy. So this is the type 2 radical hysterectomy, which can be offered in very early microinvasive 1A2 cervix cancer, in which we need not do the complete type 3 radical. This is the uterosacral ligaments being taken. So in this, we take half the uterosacral ligament, not the complete, that as we do in radical hysterectomy, and more than the simple hysterectomy. So this is the uterosacral ligament bounded between the Okabayashi space. and the Latsko space. So the bladder is then pulled down, and we complete. So at this point of time, there should not be any contamination. We complete the lymph node dissection also as required for the cervix cancer cases. Coming to the robotic surgery for these cases, robotic surgery is the technique in which there is a robot which has two main parts, the patient cart and the surgeon's console. So the patient cart is kept near the patient. The instruments are inserted into the abdomen. Camera is there. Whatever is seen in the camera will be transmitted to the surgeon. We look inside the console, and while looking at it, we operate. So the main benefits of everything we do there is transmitted in real time. So it becomes very precise and very accurate. The instrumentation, as it is there are 7 degrees of motion is provided. So main benefit of robotic surgery is not only it is a keyhole surgery, leading to early recovery. The other benefit is the vision, which it provides is 3D 10 times magnified and high definition, mainly used in the robotic surgery, but gynec cancers also it has shown benefits. So leading to less blood loss, better nerve preservation as the vision is better. The instrumentation is, it moves 360 degree at its two joints. So ultimately the flexible instruments will be helping in enhanced precision, enhanced accuracy, and ultimately early functional recovery of the patients as the nerves to the bladder and the bowel are preserved. So patient would be discharged early and having early functional recovery in all senses. So this is how the robotic radical hysterectomy would look like. We saw the laparoscopic surgery. Now we look at the robotic surgery. So the vision it provides and the flexible instruments, they really help us to identify each of the structure and perform the surgery in a better aspect. So this is the lymph node dissection being done. We are actually able to maneuver the lymph nodes in a better way, control the vessels in a better way. So this is how the robotic surgery seems to be better over laparoscopic surgery. Yes, coming to the 1B1 and 1B3. So as per the NCCN, surgery appears to be category 1. I may be biased, but yes, 1B1, 1B2, they say category 1 is the surgery. And in 1B3 and 2A2, category 1 is the EBRT. Sorry, I think it is not seen, but EBRT is definitely better when we are doing we are looking at 1B3 and 2A2. The other thing is completion hysterectomy is not done. That is category 3 recommendation. Coming to the aggression for aggression. So there is time to change in which we need to do pelvic exenteration in certain cases. So I say that in pelvis, nothing is unresectable. So whatever may be the stage of the patient, we are able to resect it. So just depending on the histology and the biology of the disease, it is us who decide if it should be resected or not. Otherwise, everything is resectable in pelvis. So as per the guidelines, they say for loco-regional recurrence, if the disease is central, pelvic exenteration should definitely be offered to these patients. So I would say the patients having recurrence, the fistula, residual or recurrent disease, they can be treated with total exenteration or anterior exenteration. These surgeries seem to be morbid, but believe me, they are not. The patients are usually discharged on 5th or 6th post-operative day. These are the patients living happily with the 2 stomas that they underwent to total pelvic exenterations. Many patients living with it. So it is not that morbid as we consider it. Coming to the last subheading, that is we can be calm and aggressive. So yes, we can be calm and aggressive. That is, we do extensive surgery and provide the patients the benefit of minimal invasive or minimal access. So under that, I would be liking to talk about neobladder and robotic exenteration. So in some cervix cancer patients, we may do neobladder. Most of the time, we are not able to make neobladder in cervix cancer, but yes, that is a possibility in some of the gynec cancers that we remove the bladder, make a small pouch from the intestine and place it at the same position as it was. So this is the neobladder. This is how it looks like. A small pouch made from the intestine. It will contain up to 300 ml of urine. To its one end, the ureters are attached. And to it's collected in the bladder, and then it is connected. Times cervix cancer patients, we won't be able to offer neobladder because this is done after CTRT. So making neobladder in these patients, the functional outcomes will not be good. So this is as per the case-on-case basis. The other important thing I want to bring about in calm and aggressive is robotic exenteration. So the morbidity of the surgery is definitely reduced as we do robotic surgery in these patients. So exenteration also we do robotically. So ultimately patient will not have any cut or a very small cut through which we will just take out the stoma. So this is the patient post CTRT with residual disease undergoing robotic anterior exenteration. The IP ligaments being clipped. All the vessels to the uterus, the vagina, and the bladder will be clipped and divided. So this is how the robotic has made the surgery so precise, accurate, bloodless. So exenteration was once considered a morbid surgery requiring a lot of blood, but this is how the robot has made it. I am operating on this lady who underwent the surgery and went home 4th post-operative day. So all the vessels are being divided. This is the levator ani which was preserved to the maximum. The same procedure on the opposite side. So hardly any blood loss. Ultimately, all the vessels divided. The beauty is that we can reach up to the pelvic floor without any difficulty. This is the rectal plane. So making the rectal plane also becomes easier even after CTRT. With the robotic, this plane is seen, I would say it is much better than doing it with open surgery. So we could preserve the rectum. This is the uterosacral ligaments being divided. Then the bladder drop down. And we'll be removing the specimen. And this patient, ultimately we did ileal conduit. As I told you that most of the patients, we won't be doing neobladder in these patients. So the specimen was removed and the patient was discharged on the 4th post-operative day. So this is how we are doing these cases. So last but not the least, these are the cases that in which the diagnosis is formed incidentally after some surgery has been done. So incidental finding of invasive cancer after simple hysterectomy. So there are indications where we might need to do complete parametrectomy and upper vaginectomy with pelvic lymph node dissections. So all these indications as per the stage of the patient is there. If we just want to remember it, these are the conditions where we do not want to, we might avoid giving radiation and chemotherapy. So in those cases, we do parametrectomy. So parametrectomy also, I would say the robot has actually helped us a lot. So in this also, this is the complete parametrectomy specimen. After this patient had undergone simple hysterectomy, we can see that this is the upper vagina clearly seen, and the parametrium, all parametrium has been removed, and these are the lymph nodes. So this is how the surgery looks like. This is in real time. I am just slowed it down so that we can identify how clearly we can identify the vessels. So the uterus has been removed, but we can actually identify the uterine vessels, go laterally so that we can remove all of the parametria even after the simple hysterectomy was done. It was a vaginal hysterectomy that was done. And after that, after this, we did this complete parametrectomy with the pelvic lymph node section. So yes, these are the surgical perspectives of CS cervix cancer patients. I would say that most of the patients are now treated with radiotherapy. So I just included all the indications and how to proceed with the surgery whenever required in CS cervix cancer patients. So that is it. I sum up with this last slide that yes, just we remember what we wanted to say, that yes, prevention is better than cure. It is our responsibility to spread awareness about the vaccine which is available against the most common gynec cancer in India. Lesser the better. That means fertility sparing surgery can be offered to the patient whenever they want it to be. Aggression for aggression, yes, if the cancer is aggressive, there is a residual recurrent or fistula, we can operate it with exenteration. We can be calm and aggressive. That is the lion from Deer, what they say, they are calm and aggressive animals. So whenever required, we can make a neobladder in certain situations, and we can do the exenteration with the minimally invasive, minimal access techniques so that the patients go home early. Thank you.
Thank you, Dr. Swati, for such a crisp message on surgical treatment of CA cervix. Done in a few, you can say, minutes. And your robotic surgery is par excellence, definitely. One thing I would like to say that regarding prevention, we are working on it with the American Cancer Society of India and FOXI, and I'm North Zone coordinator also. So till now, we are for not one dose regime for just now being said by WHO. We have to follow the 2-dose regime only till 14 years. And the Cervavac, the Indian made vaccine is well available. It is available in our city also. So it is cheaper and we should go for it. Any girl who is coming to our clinic for any purpose, we should offer, we should have a lot of awareness in our clinics. And I think in my city, most of my members of the Foxy, they are doing it because once we go for vaccination, once we are doing screening, then this part would be slowed less. The burden of this surgery would be less. Of course, you are an expert. You can do anything. Thank you so much for giving such precise note on CS cervix and its surgical treatment.
I just want to know the cost of the government vaccine that is that.
It is available in our city 2,000.
Yeah,
But
2000.
initially, we were told that it would be available in, say, 400 rupees.
But
So
that
might
has
be when government, when it is the thing available, frankly, everywhere, might be the cost comes down. And government is going to vaccinate the girls in the schools. The GO to all the states has already been sent to the by the central government to make a list, to make a nodal officer in the schools, make a list of girls from 5th standard to 10th standard so that they can be vaccinated. So all that is going on. And if it all comes, that would be a boon to us. And
Blessing to the women of India. Blessing to the women of India.
Yes, yes, that would be blessing to us.
Really.
To us, to we gynecologists also, when we see a stage 4 CA, then it looks like what to do now. It is so difficult to tell them. And if we can prevent it, it is the only cancer, these 6 cancers by HPV, they can be prevented. Why not to prevent it? So I think India is going to see that time that when prevention will be better. More cases would be prevented, and the affluent class and the this thing literate class, they're all using it. They're all using it. They are coming for it.
Be included in the curriculum that they should, all the females, all the girls must be vaccinated in the schools itself.
Yes, that is coming to. That is what I'm telling you, because government has already taken note of it, and they have the Cervavac vaccine has been just in December last. Adarpura wala got the from DGCI permission. It was procured. It has been manufactured and it has been submitted to the government. Now it is in the market also. But the government schedule, which is definitely it is going to be a bit late, but then it is already in pipeline that list to be made and all the girls to be vaccinated in the schools.
We are trying for the last 2-3 years, but it was not available. But this is good
now
news.
It is available at Harshita right now in our city.
Harshita
Cervavac is available.
So we'll see to it.
Thank you, ma'am. Thank you, ma'am, so much for sharing the session. And we will like you to be still with us because
Yes,
now
Dr. Chaturvedi is going to give some. Okay.
It's really nice to have Dr. Swati.
थोड़ा सा सीढ़ी पढ़ दीजिए. हाँ, क्या नाम है? Momita. Momita from ClearNet.
Yes, ma'am.
Put the CV of Dr. Chaturvedi.
Sure,
He
ma'am.
is the owner, proud owner of Dr. Chaturvedi Cancer Hospital and past president of UPARI. And he has had many trainings abroad. And he has been co-guide to many theses of BRD Medical College. He was superintendent.
Running a cancer hospital for so long in our place.
Yes, in Gorakhpur, the only private cancer hospital on his own.
Yes, running a cancer hospital and for so long time.
Yeah.
Right.
So, yeah. So, Dr. Chaturvedi, carry on with the videos. Momita.
Yes.
Dr. Chaturvedi, you are invited for your session. Radiotherapy in cervix.
Thank you, madam.
Sir, which videos? Which one?
Anyway, they'll talk just
The
like
first one,
The first
the
one.
first link that I gave you.
Okay.
Yes, Doctor. Please say
so.
what we saw.
It was very nice presentation by Dr. Swati. And for stage 1B1 and 1B2, surgery is fine. Since we are not getting cases in this stage, we are getting always more than second A, second B, third, fourth, and fifth. These are the category which we are dealing with mostly. 99% cases are of this type. Hardly 1 or 2 cases we are getting in early stage, stage 1B1 or 1B2. 1B1 we have not seen, very rare. It's very rare. So since these cases, early stage cases, goes directly to the surgeons or gynecologists, so they are just operating. But the cases which has been reported, we are also having equally 99 to 100% cure rate in early stages without losing the organ. Regarding 1B3 and 2A and onwards, we have to deliver radiotherapy. How to decide what type of radiotherapy we have to use is there are first we have to understand there are 2 types of radiation machines or radiotherapy procedures. Number 1 is teletherapy, means external beam radiation, and second is brachytherapy. This picture which you have seen is for the brachytherapy. So if the disease is more advanced or the pelvic lymph nodes they are involved, then we have to give external beam radiotherapy first, followed by intracavitary. Normally, we treat central part of the cancer cervix primarily, and along with that, we are treating the pelvic group of lymph nodes, obturator group, and the surrounding lymph node if they are involved. And depending upon the stage, we are treating it by the external beam radiation. We give radiotherapy by whether it is cobalt or nowadays LINAC. LINAC may be either you can go for the 6 MeV or 15 MeV depending upon thickness of the patient. So we decide what to give. From the LINAC, you can go IMRT or IGRT. IGRT is not very much effective, or rather, it's very cumbersome. And the chances of error is more with IGRT because it takes
Dr. Chaturvedi, may I interrupt? If
Yeah.
you want, you can get the second video played whenever you want. You tell Momita.
You can go ahead with the second video.
Sure, sir. I'm
Momita,
doing. Yes, ma'am. I'm doing.
this video is about external beam.
Yeah, that is for the external beam radiation. These are the machines, higher-end machine. And we deliver radiotherapy from the head side, and it will go in the.
This radiation therapy treatment machine is called a linear accelerator. It uses electricity to create powerful X-rays. During treatment, you'll lie down on the treatment couch. The couch can be moved in several directions to help get you into the right location. We will use a system of lights, lasers, and computer readouts to help with that, so the room is usually semi-dark. The machine can also move around you, but it will not touch you. The X-rays come out of the machine here. The beam of X-rays will be shaped precisely to suit your needs. The direction and shaping of the X-ray beams is different for every patient. They are planned out by your radiation oncology team using a 3D computer model of you made out of your planning CT scan. This scan and other information is used by your doctor to determine where they want the radiation to go. They also highlight normal organs that need to be avoided. In this case, the doctor has marked an area that is close to the kidneys and spinal cord. Several beams have been used to give a high dose of X-rays to the target, shown in red, while other parts of the body get a lower dose or are avoided. Your plan has been created with the same sort of precision, which is why the treating radiation therapists will take great care in positioning you the same way you were when you had your planning CT scan. Your radiation therapists will use lights, lasers, and reference marks to help position you. Sometimes they'll ask you to assist with small movements, but mostly they will ask you to keep still as they adjust your position. Once the team have positioned you and gone through their checklist, they will leave the room. You will hear a beeping sound as they go. While the staff are outside the room, they can see and hear you on closed-circuit TV. A microphone also lets them speak to you during treatment. Before treatment starts, the staff may use these robotic arms to take images. These images allow the team to see bones inside your body and make sure that they are positioned in the same way they were when you had your planning CT. If necessary, fine adjustments can be made before the treatment starts. During treatment, you will not feel or see the radiation, but you will hear the machine buzzing. Each X-ray beam delivers a specific amount of dose each day. They generally last a few seconds each, but some can go for a minute or more. Your radiation therapy team will tell you how many beams your doctor has prescribed and give you an estimate of how long it will take each day. If you have any questions at any point, the team will be happy to assist you.
So this is all about teletherapy machine. And we already explained how it works. Teletherapy machine, this is linear accelerator, and earlier to this was the selectron, microselectron machine. So first we treat with the linear accelerator or the cobalt with the for the larger area, and then when the growth shrinks, we deliver higher dose to the central part. That means cervix and the parametria and adjoining point A, point B. So as the disease advances, we have to treat whole of the pelvis, and we supplement the treatment to the localized area or the primary site with the brachytherapy. Initially, normally as a protocol, most of the center, we give 46 to 50 gray to the whole pelvis, followed by 1 week gap or 2 week gap, depending upon the reactions, and then give 2 insertions of brachytherapy, 7 to 9 gray, 1 week apart, and that completes the treatment. And it is giving fantastic results. So this is all about the external beam radiation. Regarding stage 4 cases, the question was asked by Dr. Deepti Chaturvedi whether you will give radiotherapy to patient with fistula and RVF, LVF. So normally we don't give. It is contraindicated to give radiotherapy in RVF or VVF. But we have seen whenever we receive a patient with VVF, I had myself tried, we have put in catheters for a long time, and treat them with chemotherapy. Everything heals off. Even the BVF is
Visualizing.
yes, and then later on we can consider for
Things.
radiation. Otherwise, radiation will be used as a palliative tool to control the pain and all. Dr. Swati has very nicely explained about the exenteration. Although it is surgically, you may not have very mutilating surgery type of thing, but the life after that surgery becomes hell. All the time they are carrying a stoma and colostomy and urine bag if it
And
works.
cost with the fourth stage, it must be huge for that. For the
Sir,
fourth stage, and survival is less.
Only after
Survival
the
is less.
only
Pardon?
even if there is a residual recurrent disease after radiation, then only we offer the exenteration.
Yeah.
Definitely, even in fistulas, as you are saying, radiation, I think, would cure 50% of these patients, even with the fistula. So 50% of them would not require exenteration. Only those patients who will have residual or recurrent disease after radiation, those patients we offer exenteration, and these patients definitely do good. Stroma is better than having RBF or BVF when other modalities are not there. So we offer then
think,
only. It is not. It is
I
not.
think there must be a control study regarding this. Let us see the results. And,
Actually,
we
fourth
should,
stage survival,
early.
they have
Yeah,
mentioned
that's very
without
true.
treatment is 7%. With treatment, how much it will be?
It is
So
50%.
like
So
50%, fourth stage.
4A, not 4B.
How long they live? 6 months, 1 year, 5 years.
5 years survival.
The 5-year survival will be 50%.
Will be
Very nice
50%.
survival with surgery.
Yes, sir.
Otherwise, chemoradiation, it's fine.
Ah.
These patients, sir, it is not. It will be
Is
always
it mentioned somewhere? Is it mentioned in some guidelines? Ki,
Yes, madam, I just
you operate and then the life is 50%.
The NCC guidelines have medical studies also. The studies have reported this much survival. So definitely CTRT is the first choice for these patients. So
Followed
we
by
offer
surgery.
CTRT only those patients. See, in stage 4A, 40 to 50% would have residual or recurrent disease after CTRT. So for those patients, we offer exenteration. Not for, we will definitely give CTRT first. If the patients are treated, they are happy, we are happy. But if there is a residual or recurrent disease, then we offer the exenteration, and these patients actually do.
Dr. Chaturvedi, I would like to ask you one thing. I've seen you giving second radiotherapy, 10 or 10 gray or something in recurrent CSEX.
That's part of the similar chemotherapy. That is for the boost, not extra. It is included by reducing the pain.
One patient had long time back radiotherapy and there is a recurrence. Then do you give the 10?
Yes.
10, 15?
More than
So
10.
that is better, or surgical exenteration is
So
better?
if what he is saying, she can do it robotically, it's better than the open surgery. Open surgery, it is definitely.
I'm not talking about open surgery. I'm talking about robotic only. Chalo, best kya hai for the patient?
I
What
will
is
always
best for
exenteration whenever possible. So
Whenever, that's the right answer. Whenever possible. If it is possible to operate it out and take out all the things, it's very nice. If it is not possible, then you have to go for radiotherapy and chemotherapy. There is no other way.
So first option will be CTRT. If there is a residual disease, then, and if we can remove 100%, then surgery. If there is a recurrence after a long gap, then we can offer second radiation. Then definitely second radiation with curative intent. Yes, we will send for radiation. But if we are not able to offer the curative intent, then we have the exenteration whenever we are doing CCZ, the R0 rejection.
Okay. And what's your cost for?
Ma'am, cost will be varying from 2.5 to 5 lakhs, including everything. 2.5 for open and up to 5. I would say there are various models and the options given to the patient. So the minimum would be 2.5 and the maximum will be 5.
So is it covered under Ayushman? Is it covered under any?
No.
That you don't know.
They cannot afford.
It must operate. It is there.
Ayushman total government gives 5 lakhs, na? Total
Yes, total 5
to
lakhs.
any person.
It's
But
not
the
feasible and
for
it's not
safety
a
they
good-
give 1,000 only, so that is not possible in that.
Yeah,
So I
not
don't operate any case under I.
For surgery, they give hardly 25,000, right?
For exenteration, they may give 40,000, but that is not possible to do.
That can't.
even the
कोई नहीं
anesthetic charges and OT charges are not coming in that.
too much. हो नहीं सकता उसमें.
Because we have to manage the post-operative period. We give
Yes.
albumin. So every injection, albumin will cost 8,000 to me. So giving 4 albumin will cover the Ayushman.
Yeah, definitely.
I have to give the result.
Correct.
If I am taking in the patient, the responsibility lies on me. So these are my exenteration patients. I showed the picture also.
And one more thing I'll ask you, we see fourth stage because of the, what you say, its involvement till the pelvic bone, iliac bones, there's mostly hydronephrosis.
Ma'am, that is
and then will she be able to tolerate surgery well?
Yes, ma'am.
हाइड्रोनेफ्रोसिस है फिर भी एनेस्थेटिक ड्रग्स कैसे निकलेंगी ना वो हो जाता ना
Hydronephrosis is
किडनी
not
भी
a contraindication for surgery. It
pardon
can be done. Hydronephrosis is not contraindication for surgery.
it's not contraindication but
the
जब
thing is,
creatinine clearance ही नहीं होगा तो toxic elements of the anesthetic
parametrial
drugs.
resection. He is doing parametrial resection, so she can resect out the
Yes,
ureters as well. So
Yes.
There's no problem of that. I'm saying maybe stenting भी करेंगे तो वो भी तो compressed होगा ना because of the involvement of the वो भी वो होगा तो कैसे stenting भी करेंगे वो तो या तो nephrostomy करके पहले उसको ठीक करो and then
no.
for the operation.
I think during surgery they can repair it. Whatever is going inside the parametrium is resected out. So it will take not much time from anesthesia to resect out the ureter. The way
can reduce the tumor burden by chemotherapy.
So I think it can be done.
The anesthetist will answer
Swati
this
should be
better.
answering this question.
Anesthetist will answer, ma'am.
नहीं एनेस्थेटिस्ट क्या करेगा उसमें वो तो
Nothing to
कहेगा
do.
कि आप
रिफ्यूज
जल्दी
कर
कर
देते
लीजिए
हैं रिफ्यूज कर देते हैं ऐसे केसेस रिफ्यूज कर
how much
देते हैं
time suppose there is hydronephrosis ureter is in the parametrium how much time it will take to
About.
resect it out what about the anesthesia problem
creatinine is normal, then there is no problem. If the creatinine is deranged, if even if it is 2.5 to 3, they would say no issue, not the PCN is good. If it is more than that, we do the PCN first, let the creatinine come down, and then we do the surgery. Ultimately,
that is what I
the patient will
percutaneous drainage.
later on she will not. So we can remove the later.
Yeah, it was really good and so nice of you, Swati, to have answered all the questions and all the queries.
all the queries and
Yeah.
Dr. Chaturvedi to show the videos very nicely for radiotherapy.
Yeah, that is what I told him.
I
Na?
have not seen the
मैंने कहा मुझे ही कई चीजें नहीं मालूम है. Being with you also, I still don't know so much about radiotherapy. So थोड़ा तो it should
Not be
answered.
completed without radiotherapy.
It is multidisciplinary.
Swati, thank you. Nice being with us this evening and giving your inputs. I think
Really, ma'am,
audience
it was a blessing. It was a blessing to be with you. Thank you so much, ma'am.
Okay, thank you.
Okay, thank you. So we leave for today. Clarinet, you would like to conclude? You may give your vote of thanks. And
With
we
all
thank
due,
you.
thank you so much, Deepti
Hello?
ma'am, and to all of you. And with all due permission, I'm closing the session for today and looking forward to hosting you again.
Okay.
Thank you so much. Take care.
Okay. Bye.
Bye, ma'am.
लीव क्यों नहीं हो रहा है